Hi students, welcome to this session of integrated questions of forensic medicine discussion for INI-CET 2023 examination. Now in past few days we have been bringing you a very well crafted series of integrated discussion. Today in the integrated discussion I am with you alone. The reason for it is that I wanted to bring a very comprehensive and a holistic view for the students for all the questions of forensic medicine that comes in an INI-CET exam. And for that we had to have different areas of core forensic medicine being covered, and thus it was very important that I should bringing you all the focus on the hot areas of forensic medicine. But not to miss the component of integration, I have included picture based questions along with the clinical scenarios, which is kind of a hallmark of producing a question or making a question in an INI-CET exam. So we are utilizing that new concept of integration in today's class, right. So before we begin today's class, let me tell you something about what are the key areas which are routinely, commonly and repeatedly asked in the examination of INI-CET. So if you look at forensic medicine, there are so many topics in the subject itself, but then there are few topics which are very hot topics as far as INI-CET examinations are concerned. 5 most important topics in context of INI-CET examination are asphyxia, mechanical injury, thermal injury, identification and toxicology. If you look previous years questions, we will have questions being repeated in these topics very frequently. So these are the 5 areas which we are going to cover up in our discussion today also. We are not going to miss any of the hot areas that come the subject. With that, let's begin with our first question for the day, and first question has a written component and along with it a picture also. Let's see that. The question says a person has died with the method shown in the picture, and then we have a picture in the frame itself. All the correct statements are, and then there are 4 different statements given with it. So first of all, let us understand the question. The question is very simply saying that there is a method of dying or killing, I should say, which has been shown in the photograph, and after looking at the picture you go through the statements and we need to tell what are the correct statements written in the frame. So if I were to increase the size of the picture for all of us have to have a better look, what do we see? The photograph contains a victim who seems to be probably a female, seems to be, yeah. So there is a victim here, and then there are 2 assailants or 2 killer. One assailant is sitting on top of the body of the victim, the other one is sitting on the head end, and that person who is sitting on the head end is actually pinching the nose and the mouth of the victim. Now, although asphyxia is a very favorite topic of INI-CET examinations, generally there is always a question which is from the chapter of asphyxia and which is not from the usual methodologies of asphyxial death. See, when I say usual methodologies, it includes hanging, strangulation, drowning. So INI-CET examinations or previously AIMS examinations or PGI examinations, they always used to talk about some alternative method of asphyxial death. And this method of asphyxial death, which is been shown in the photograph, it is called as burking. Okay, this is called as burking, B-U-R-K-I-N-G. It is a process where the victim is on the ground, the assailant sits on the chest of the victim, and the assailant pinches the nose and the mouth of the victim also, and the victim die because he cannot breathe, right. So, what do we see in the statements? Statement says it involves traumatic asphyxia. It seems to be a true statement because there is an assailant sitting on the chest, and any weight on the chest amounts to a concept of traumatic asphyxia. Second is smothering contributes to death, and that is also correct because the assailant is pinching the nose and the mouth of the victim. So, the victim is simultaneously getting smothered also. Third statement is a person dies of water entering in the respiratory passages, and that is absolutely wrong. And the fourth statement is it requires at least 3 assailants. Now, when we talk about burking, typical burking generally requires 2 assailants, as you can see in the photograph. It can be done by one person also. The person who sits on the chest simultaneously is pinching the nose also, okay. But it typically does not require 3 assailants always. There can be more than 2 people, but it is not mandatory that to cause burking every time 3 people or more has to be. So, even this is a wrong statement, right. So, what we are left with is option number 1 and 2 are correct, which means in this question option B is the correct answer. So, let us have some more discussion on this concept of burking. As I said, burking is a combination of traumatic asphyxia and smothering, right. It can be performed by one person who can sit on the chest and pinch the nose and the mouth of the victim. It is also known as it is also known as Burke and Hare method of killing or homicide, right. Now, as I told you earlier, INI-CET examinations, they are very fond of asking certain alternative methods of asphyxial death, and one very important alternative method of asphyxial death is also called as positional asphyxia, called as positional asphyxia, right. Positional asphyxia, it rhymes and sounds similar to traumatic asphyxia, but traumatic asphyxia and positional asphyxia are entirely different concepts. See, what happens in traumatic asphyxia is there is a weight on the chest wall, or the rib cage is broken like it happens in flail chest, so that lung cannot expand, okay. Whereas in positional asphyxia, there is no weight on chest wall. The position of the body is such that the process of breathing cannot happen, and if a person is stuck in such a position for a long time, eventually he will die, and such a position is called as a jackknife position, or you can say a hairpin bend of the body. Hairpin bending of the body, also known as jackknife position. You can also call this position as nose to knee bend of a body. So, if you are standing and you bend to attempt to touch your knee with your nose, your lungs go below the level of diaphragm and your respiration is compromised. If your body is stuck in this position, that's called as positional asphyxia, which is absolutely different from traumatic asphyxia. So, why am I highlighting positional asphyxia? As I told you earlier, INI-CET examinations, some alternative kind of asphyxias which are not usual are often presented in the exam. It does not mean that normal asphyxial methodologies doesn't come up in the exam. So, it is also important to remember certain important point about normal neck compression methodologies also, and that is exactly what is being included in question number 2. So, let us go and see the second question, the section of asphyxia itself. Now, in second question, we have a body comes for autopsy with ligature mark on left 1/3 of the neck. So, one important aspect which is given in question is that ligature mark is present on left 1/3 of the neck. So, it is not completely present around the neck. Saliva is dribbling from left angle of mouth. Okay, so we also have dribbling of saliva coming from left angle of mouth. Also, there is a ligature material present in the neck. The ligature material has a knot present on the right side of the neck. So, there is a knot which is present on the right side of the neck. Everything else is on the left side of the neck. Okay. The diagnosis and the expected finding will be. So, there are two components to the question here. One component is what is the diagnosis, and second is what is an expected finding. So, there is a combination of diagnosis and expected finding given in the options. Okay. So, based on the scenario which has been described in the question, let us first of all try to reach the diagnosis. Now, we see that there is a ligature mark which is present on left 1/3 of the neck, which means this ligature mark is an incomplete ligature mark present only on left side of the neck. Okay. Dribbling of saliva is present on left angle of mouth. So, dribbling of saliva, which is a very important indicator for a process of hanging, more importantly ante-mortem hanging, to an extent that we say that if ante-mortem hanging is to be confirmed, one of the most important sign is dribbling of saliva. So, this confirms hanging, and ligature mark being incomplete in the neck also is basically a component of hanging. So, these are the two lines reading which we can differentiate that it looks to be a case of hanging, not a case of ligature strangulation. So, at least hanging is made out from these two components itself, which means if you look at options, there are 4 options given: strangulation with right eye open with dilated pupil, hanging with right eye open with dilated pupil, and then we have strangulation with left eye open with dilated pupil, and then we have hanging with left eye open with dilated pupil. So, at least 2 options are automatically out of choice. These 2 options are options of strangulation. So, possible answer could be from B or D. But if you read the rest of the question, it says a ligature material that is present on the neck, a knot is present on the right side of the neck. Now, the knot is present on the right side of the neck, and the compression of that knot on the cervical sympathetic trunk causes a post-mortem appearance in that dead body, and that post-mortem appearance is on the ipsilateral side of the compression. The eye remains open with dilated pupil. On the same side of compression, the eye remains open with dilated pupil, as we have shown this in the photograph here. You can see in this photograph that there is a knot which is present on one side of the neck, and because the knot is putting a pressure on that side of the neck, the eye of the same side it remains open with dilated pupil, whereas the eye on the other side it is closed, or it may be partially open, right. This is called as la facies sympathique. This is called as la facies sympathique, and presence of la facies sympathique also is an important indicator of an ante-mortem hanging, right. So, if you go back to the question itself, what is the combination that is the most correct combination given in the option is that it is a case of hanging where the right eye is expected to be open with dilated pupil. The answer is presence of la facies sympathique. So, correct choice is option number B or option B. Great, good. So, we have got few listeners available with us. We have K. Harsha, we have another aspirant, we have Ibraze. Welcome to all of you, and I can see that some of you are looking forward to answer certain questions, and looking forward to have certain more viewers joining us, and if they would try to attempt answering certain questions simultaneously, it would be a wonderful preparation for them. Right, for now let us move on, and let us now take a question on mechanical injury. Mechanical injury is one topic in forensic medicine without which no forensic medicine paper in any entrance examination is complete. It has a vast domain. There are so many different type of injuries, so many different type of weapons causing injuries, so many different scenarios which causes injury. In INI-CET exam, one of the repetitive pattern is a scenario of injury, right. So, scenarios of injuries are commonly asked in INI-CET exam, and a very particular type of mechanical injury, okay. And because they are very important and very repeatedly asked in the examination, I have added one question each from both the sections. So, first we are going to see scenario of injury, right. It says that there is a dead body, dead bodies arrive in mortuary after bomb explosion. What finding will confirm injuries due to flying missile? Okay, very common asked question in INI-CET exam. Still a very important thing to understand. Here we are talking about blast injuries. Okay. Now we will come back to the answer of this question later. Let's first of all try and understand the explosion of the or the blast injury. So when we see it, it says that minimum pressure of about 100 pounds per square inch is needed for a tissue damage in human. So if tissues are provided with pressure of 100 pounds per square inch, good enough to damage a tissue. Bomb explosions can produce pressures of 1000 tons per square inch. So look at the amount of pressure that tissues have to go through in case of an explosion. When an explosion happens, how human body is impacted? What are the different factors in an explosion which impacts the human body? We have disruptive effects, we have burns because explosion produce high temperature, and temperature of gases of explosion could be greater than 2000 degrees Celsius. So that much amount of high temperatures can be produced if a person is very near to the explosion. Air blast, a very important factor. Air blast basically is a shock wave spreading concentrically from the site of explosion. This shock wave can throw the body of the victim in air, causing blunt injuries. So consider a blast happens in the center, it is going to push all the air around that explosion concentrically outwards in 360 degree. So there will be an air pressure going outwards in all the direction. So anybody who is going to be impacted with this air pressure is going to be thrown with that air pressure. Okay. Then we have flying missiles. Flying missiles are nothing but components of the bomb itself. The bomb is made up of iron, any other metal components, and if anything else has been put inside the cavity of that bomb, which could be nails, broken glasses, or any other material which can flow after explosion, and splinters of those particle can go and hit the body of the victim. Those are called as the missiles coming out of the explosion. Then we have falling masonries, because the explosion, the blast that happens, is going to disrupt the nearby structures, the buildings, and those buildings can fall and cause injuries to the victims upon which those buildings fall. Then we have fumes, explosions in a confined space. If an explosion happens in a confined space, carbon monoxide can cause asphyxia. So these are different methodologies by which a person can be expected to be impacted in cases of explosions, right? Now, as I just told you about that, air blast. Let's see how exactly this air blast concept happens. So consider, let's say if there is a bomb here and an explosion happens, the bomb disrupts, right? So this kind of concentric waves of air will be pushed outwards. So the direction of push will be this, right? So if anybody is trapped as a victim standing near the bomb, what will happen is that this person is going to be flown in the air and his body may land either on the ground or maybe on any other structure on the ground. So, he is going to have injuries on his body because of that impact that his body sustains, because his body has flown and then landed onto a structure on the ground. So, he may end up landing here, right. So, this is the indirect effect of that bomb blast, the air pressure effect that happens and people sustains injury. But in the question, if we come back to the question, we read the question correctly, what was being asked? What was, what will confirm injuries due to flying missile? So, how these flying missile impact the person is that when this bomb blasts, whatever is the component of this bomb, there could be nails or any other structure present inside the bomb, and once the bomb blasts, even the surface of the bomb, it gets disrupted, and those sharpnels, they fly in all the directions to impact the body of the person, and these sharpnels are going to be impacting this person and thus producing abrasions, contusions, and as these are sharp objects, they will puncture the body in multiple places, producing what is called as punctate lacerations. This triad of injury produced by the flying missiles impacting the body of a person when he is exposed to an explosion is called as Marshall's triad. This is called as Marshall's triad, a very important triad of injury which has been asked many times in the examination, and there would be no surprise if it is still asked in the exam. Okay. So, correct answer, if we come back to our question, is where do we find Marshall's triad? And Marshall's triad is depicted in option A of the question. You can see presence of abrasions, contusions and puncture lacerations. This is called as Marshall's triad. Right. Let us move to our next section, and by the way, in the meantime, there are some more people who are answering the questions. We have Dr. Reformer, good evening, very good evening. We have Vorashre and yeah, Reformer and Vorashre, two more people. Very warm welcome to the class, both of you. Okay, let us now talk about mechanical injury. Now, this question, which has been framed out of the concept of mechanical injury that we are going to discuss in the question, this is one of the again very commonly asked question in concept in context of INI-CET examination, and in the context of when an examiner thinks where should I ask a question from the aspect of mechanical injury, this is the first thing that comes in the mind of the examiner. Okay, let us look at the question itself. The question says X is attacked. His left parietal scalp has a wound as shown in the picture. So, there is a picture which has been given to us and there is a wound which has been depicted in that picture. The margins of the wound are regular. So, that is an important information. The margins of the wound are regular. Okay. Two doctors have diverse opinion. So, two doctors are examining that victim and they have diverse opinion. One says the injury is an outcome of blunt trauma. The other says it is due to sharp weapon. The other one says it is due to sharp weapon. So, there is drastic difference in opinion. One say it is blunt trauma, the other say it is sharp weapon. The margins of the wound are regular. The photograph of the wound is shown to you in the picture. The area of the body which is impacted is parietal scalp. Okay. Let me complete the question, then we will come back to the dissection of the question itself. The correct statements helpful in determining it to be a blunt force injury are. So, basically after giving whole scenario, the question is asking out of the given statement, which statements will prove that it is an injury by a blunt force acting body. Now, first of all, for all those students who know the concept of this question and the stem of this question, it should not be difficult for them. But for those who do not know the concept and the stem of this question, is that we are talking about blunt force conformation and simultaneously we are saying that margins of the wound are regular, because the wound which has been shown in the photograph here, as you can see, it is kind of a linear splitting of the skin which is clearly visible. So, it is a three-dimensional injury. There is a length, there is a breadth to which the skin has split, and there should be certain depth. If we spread the injury outwards, we will be able to see the depth. Okay. And a three-dimensional injury produced by a blunt weapon is laceration. But when we say laceration, lacerations tend to have irregular margin, and in the question it is given that the margins of the injury are regular. Regular margin, a three-dimensional longitudinal injury goes in favor of cut, also called as an incised wound. Now, incised wound is a wound which is three-dimensional produced by a sharp cutting weapon where length is the greatest dimension. And if you look at the photograph, it typically looks like an incised wound. So, what is the catch in the question? Catch in the question is the examiner wanting a student to test on the knowledge that if I say parietal scalp, can a student think about the medico-legal importance of this area? The medico-legal importance of this area is parietal scalp has proximity of bone beneath it. If you see skull, the skull is in proximity with the scalp, the intervening connective tissue is minimal or scanty. So, if that area of skull is hit on top even with a blunt weapon, what is going to happen to the skin? The skin is going to be pressed between two blunt surfaces, and as the skin gets pressed between two blunt surfaces, one blunt surface is the skull itself and the other blunt weapon is being used to hit on the top. The skin splits open. This kind of a laceration is called as a split laceration. The whole concept of the question is ability to identify split laceration. Okay. Split laceration is skin splitting between two blunt surfaces, right? And when this splitting happens, the margins of the wound are very regular. That is its medico legal importance. Here margins are regular, and as the margins are regular, when somebody primarily inspects the wound, it doesn't really appears to be a lacerated wound. It on the contrary appears to be an incised wound, and that is why these kind of wounds are also called as incised looking lacerated wounds. Okay, they are actually lacerations because they are product of blunt weapon injuries, but they look like incisions because their margins are regular. The reason is they are present on bony prominences of the body. That is what the examiner wants to test a student, that whether the student has this kind of knowledge, that if bony prominences of the body are impacted, and if a photograph of a bony prominence of the body is shown to a student where there appears to be a linear kind of a cut on that area, can a student really comprehend that it could not be an incised wound, it could possibly be a blunt weapon also, right? With this knowledge, now let's try and read the statements, because our main question is not the identification of injury. We have identified the injury as probably split laceration, but question has already mentioned it to us that the correct statements in favor of it being determined as a blunt force impact injury. What are the correct statement? So let's see. Presence of tissue bridges. Now that's a true statement. Tissue bridges are component of lacerated wound. Okay, tissue bridges are nothing but a fiber of tissue joining both the margins, right, which is a hallmark of a laceration. So tissue bridges will be present in split lacerations also. Contused margin, again a true statement. If you are going to wash this injury all around, you will be able to see if a blunt force had landed on the body, the margins will also develop certain contusion. Crushed hair at margins, again a true statement. If you will see the hair which are present on the margins of the injury, because a blunt force has landed on top of the tuft of those hair, even the hair segment would be crushed there because of the blunt force landing on the hair shaft. Now this is not a naked eye finding, it is actually a microscopic finding. If let us say this is how a normal hair shaft looks in microscope, and what if a blunt force impact has been delivered, if you will see the edges of the hair would appear splayed like this. Okay, this is crushed hair. If we have that kind of a splaying appearance on microscope, we can say that it is a product of a blunt force impact. Periosteal cut beneath the wound. If somebody would have attacked the victim with a sharp weapon, it would have cut the scalp and probably the periosteum beneath also, and as it is not basic sharp weapon which has been used, so periosteal cut does not go in favor of it being a blunt force impact. So that is false. And clean cut hair ends, again clean cut hair ends will be seen when a sharp edged weapon is used to deliver the injury on that area, even that is false. So what we are left with is Option number 1, statement 1, statement 2 and statement 3 are 3 statements which are going to go in favor of this injury being called as an injury of blunt impact, which means the correct option again is option number B, right. The correct option is option number B here, right. We also have Ravi Kumar joining us. Welcome, Ravi Kumar. Let's move to our next question. Again from the section of injury, and this question is around the scenario of injury. Okay. So, let us take this question. A 25-year male after losing in love decides to die. Okay. So, age is an important indicator, is a very young adult person. He starts to cut his neck, but while he was still hesitating, a family member snatches the blade away from him and save him. In the process, he developed cuts in the neck as shown in the picture. So, there are certain cuts in the neck which are shown in the picture, right. What character of this injury differs it from self inflicted injury? Okay. So, first of all, the first thing is that we need to identify the question very appropriately. It says there is a young adult, 25 years male, he loses in love and decides to die. He decides to die by cutting his own throat, and when people decides to do that, they usually take a sharp weapon to cut their throat, and they know that throat has important vessels. If they cut, they will bleed to death. Okay. But they do not have courage enough to give the first cut as the decisive cut itself. So, hanging on to that blade for a while, they hesitate. That is the moment of hesitation. Okay. They are gathering courage to give a deeper cut. Okay. Unknowingly or by default or unconsciously, while they are hesitating holding that weapon, they end up producing superficial multiple injuries in the beginning of that cut. Those are called as hesitational cuts. Presence of those hesitational cuts in the beginning of a deeper decisive cut in a dead body indicates that the person has committed suicide, because it indicates that hesitation, which is hallmark of committing suicide by cutting someone's own throat. Okay. So, what has been shown in the photograph, these are nothing but hesitation cuts. So, what we very clearly see in photograph is presence of these hesitation cuts in the neck, right. Now, the real question which has been asked is, what character of this injury differs it from self inflicted injury? So, if you read the question correctly, it has two components. In the first component, we have to decide what exactly are the cuts which are shown in the picture, and as I described it to you, the cuts are nothing but hesitation cuts. Okay. And the second component of the question is, how do you differentiate it from something called as self inflicted injury? We will come back to answer the question, but let us have the differentiating points first. Let us try and understand. See, when we talk about a self inflicted injury versus a suicidal injury, hesitation cuts are hallmark of suicidal injury, right. We have already talked about it. There is first of all a difference between the motive of these injuries itself. In self inflicted injury, the person does not want to die. He wants to produce an injury on his body himself, but his motive is to blame somebody else. So he wants to produce injury on his body himself and then go to an FIR, a police, and lodge an FIR that somebody else has attacked him. So the whole concept of production of injury here is the blame game, right? So if you'll see self-inflicted injury, the motive is blame on other person, whereas if you will see hesitation cuts, which are hallmark of suicidal injuries, hesitation cuts are due to a motive that a person wants to die. So motives are entirely different. Now consider, if a person wants to die, where would he produce that injury, which is suicidal injury accompanied with hesitation cuts? Those are going to be present on a vital structure or a vital area of the body. So in suicidal injuries, we have involvement of vital area or vital structure of the body, and versus if you will see self-inflicted injury, the person only wants to blame somebody else. Would he cut a vital area of his body? No, because cutting a vital area is very dangerous and everybody knows that. So self-inflicted injury are going to be present on non-vital areas of the body. So here we see non-vital area involvement. How about number of injuries? Self-inflicted injuries are going to be multiple in number. Why? Because nobody is going to produce one injury on his body and then go to police and report, say somebody has attacked me with single injury, right? So here we have multiple injuries. How about hesitation cuts? Are hesitation cuts also multiple? The answer is yes. Now both the injuries are multiple in nature. And last is severity of injury. Self-inflicted injury, a person is producing an injury on his own body. Would he want to cut himself very deep? The answer is no. He is expecting to cut very superficially so that he can bear the pain and there is no complications, right? He does not want to bleed to death. So here the severity of injury is that these are superficial injuries, right? How about hesitational cuts? See, hesitational cuts also are superficial only. It's only that once after a while of hesitating, a person gathers enough courage, he may end up giving a single deep cut. But before that, whatever hesitation time was there, they will only produce superficial injuries. So even these are superficial. Okay. With this information, if you go back to the question, what do you see? In the photograph itself, we can see that injuries are very superficial, right? So how can you now differentiate a hesitational cut from a self-inflicted injury? That option number A says that these are superficial. So both hesitational cuts and self-inflicted injuries are superficial. Option number C, it says usually not associated with a deeper wound. Now we understand that hesitational cuts are usually associated with a deeper wound because they are product of concept of suicide. So they are associated with deeper wounds, right? Singular injury, no, both the injuries are multiple. So what is left with? Its presence on vital area. Its presence on a vital area of a body is what differentiates it from a self-inflicted injury, because self-inflicted injuries are present on non-vital areas of the body, which we have seen the discussion earlier. So, correct answer in this case is option number B. Right. Let us move further and let us take up a question around thermal injury. A prototype question which I have included in this discussion, and haven't been asked in the examination yet, but it is a very important concept to understand in thermal injury. When we talk about thermal injury, assessment of burns is important, that is rule of 9 given by Wallace. So, questions are often asked around that, but that is something which is easily understandable by every student. Heat hematoma, heat ruptures are important because of prolonged burning of a dead body. But very seldom I have seen any question being asked on the format that we are discussing right now. It is an investigation associated with burns. Let us read the question. Question says, it is alleged in a case of death due to flame burns that kerosene was poured upon the victim from head to toe and then fire was set upon him. The question is very clear that there is a flame burn and kerosene oil was used. So, some inflammable substance was poured on the body from head to toe and then the person was set on fire. What finding during postmortem will confirm the allegation? The question is very straightforward. It says that it is being alleged that the person has been put to fire after pouring kerosene on his body. What finding should you get in the body which confirms this allegation? See, when you burn a body, the clothing catches fire, because of which it engulfs all the body areas. But when you pour kerosene on the body, because the kerosene burns pretty quickly and pretty fast, it is going to engulf the body areas more fast. Now, when body catches fire, hair which has the surface keratin, they do not readily catch fire. So, when the hair come in contact with the flame burn, hair commonly gets singed, they do not catch fire at self. Okay. So, if you are going to burn a body, the hair present on the head, they will singe, they will not burn. But if an inflammatory substance has been poured on the body, even the scalp will catch tremendous fire. As a result, lot of area of scalp can burn from the root of the hair itself, and when that happens, a typical bald patch is created on the head with loss of hair roots from that area of hair which has from a bunch of hair which have caught fire because an inflammable substance was poured onto the body. That bald patch on head is an indicator of an inflammable substance which commonly is kerosene oil itself poured on head, and that is why the tuft of hair caught fire, they all got burnt from the root itself, creating a bald appearance on the head. Highly important clinical sign of diagnosing an inflammable substance being poured on the body before setting the body on Okay. Uh, if you look at other options, as we have singeing of scalp hair can be present even if we do not use any inflammable substance or kerosene. So, that can be seen in normal flame burns also. Heat ruptures can be seen in normal flame burns also. It all depends upon uh, prolonged burning of the head. So, even in a normal case of burn, if there is a prolonged burning of head, because head is near the source of constant fire, heat hematomas can generate, and same can happen uh, with heat ruptures. Okay, sorry, the first option was heat rupture, third option is heat hematoma. So, heat ruptures and heat hematoma are indicators of prolonged burning of the muscular area of the body or the head. So, both of these are indicators of prolonged burning. And in the question, the question is not asking about what is an indicator of prolonged burning, what will tell, what PM finding will tell us that the body has burned for a long time. No, the question is very discreet and direct. It is typically asking us what finding during postmortem will confirm the allegation that kerosene oil was poured on the body, and that is presence of bald patch, right. Very interesting phenomena, very less talked in the examination, but it is a very important finding in cases of birth, right. Uh, so, Ravi Kumar, no, we got the answer wrong. He gave answer as heat hematoma. As we have just discussed, the correct option is presence of bald patch. Heat hematoma and heat ruptures both are indicators of prolonged burning of the dead body. Let us move forward to discuss questions on identification. We have got two questions on identification, fairly easy question, fairly easy, because in identification we need to rehearse and remember a lot of aspects of sexual differentiation. Now, I would say if I have to consider one question coming from the area of identification in an INI-CET exam, would it come on race? Probably not. Would it come on the concept of age? Probably not. Would it come on the concept of age assessment? Probably not. Stature? Probably not, because repeatedly questions have come upon sexual differentiation, and there are two very important bones which help in differentiation of male or female. The two important bones are pelvis and skull. So, commonly question comes around this aspect of sexual identification. So, we have included one question from that section itself. Let us read the question. It says, a skull is bought for forensic examination. What characteristics will identify it as a female skull? Very simple, straight question. And there are 7 different characteristics given: deep forehead, small glabella, less prominent supraorbital ridges, prominent zygomatic arch, less large frontal eminence, narrow and short mastoid, high nasal arching, right. Now, this is something that we need to remember, we need to retain, but still there is a very small concept here. Let me highlight that remembering concept for you. We will come back to answer the question later. The concept is very simple. If you see the differentiation of a male and a female skull, everything is large or more prominent in male except frontal eminences. Frontal eminences are the exceptional feature in female skull, those are larger than male, right. Everything else, general appearance, male skull is larger. Glabella, rough and more prominent glabella is seen in male. Forehead, it is steep, less rounded. So, more rounding of forehead is seen in female, more rounded forehead. Male skulls are supposed to be steep skull, so straight and steep, and because the female skulls are more rounded, the frontal eminence is more prominent. Supraorbital ridge, prominent in male. Zygomatic arch, heavier and prominent in male. Mastoid, wider and longer in male. Nasal aperture, high and narrow. So, when we say high, it also is a state of prominence, right. So, everything is prominent or wide or large or heavy in male. The only exception is frontal eminence, which is large in. With this remembering concept, let us go back to answer the question. Steep forehead, we have already seen, this goes in favor of male. Small glabella goes in favor of female because males tend to have rough and very prominent glabella. Less prominent supraorbital ridges, when it is less, it is automatically in favor of female. Prominent zygomatic arch, prominent, goes in favor of male. Large frontal eminence, now this is the only large thing which goes in favor of female. Narrow and short mastoid, narrow, again female. High nasal arching, high again is a sign or a symbol which is associated with prominence. So, it goes in favor of male. So, what do we have out of the 7 options which are favoring female skull? We have option number 2, we have option number 3, we have option number 5, we have option number 6. So, correct answer is option B, 2, 3, 5, right. These are not difficult questions. Yeah, this time Ravi Kumar, absolutely correct answer has been given by him. These are not very difficult questions, and let me tell you, questions like this are asked in INI-CET examination, but then we should be able to differentiate the sexual differences between male and female skull and also male and female pelvis. And remember one more thing, when we talk about male and female pelvis also, the concept remains the same. Generally, most of the features even in male pelvis are larger or more bigger as compared to female pelvis. So, whenever you don't remember something, just stick to the basic concept. Larger and bigger goes with male, smaller and lighter goes with female, right, when we are talking about bones. The only exception is in the skull bone, frontal eminence is large in females, not in. Let us move on and let us take another question on identification. This question comes from individualization by dactylography. So, let us read the question. A known criminal is sent to jail. In jail, his current fingerprints cannot be obtained as they are permanently damaged. So, one important key area that has been notified in the question is permanent damage of fingerprint, right, and thus no matching can be found with his old fingerprints already existing in record. So, no matching can be done because his current fingerprints are permanently damaged. All conditions can cause it except, right, leprosy, celiac disease, radiation, electrocution. The correct answer here is option B, celiac disease. See, this is basically a question from forensic science domain, and there is always has been an overlapping between the investigative forensics and the human aspect of investigative forensics, that is forensic medicine, but still knowledge is knowledge, right. Fingerprints are unique, they never change throughout life, they do not once they are present, they don't disappear, they don't vanish. But then there are certain conditions which can bring character change of fingerprints over a period of time. Okay, let's see what are these conditions. First is permanent damage to fingerprints. It can happen in cases of electrocution, leprosy, or radiation. Okay. Then we have distance between ridges changed, but the pattern remains the same. So there is no change in the pattern of the fingerprints, but the distance between the ridges of those fingerprints, that increases, and understandably the answer will be simple, it's acromegaly. Okay. Third is ridge alteration. The ridges of the fingerprints, there is certain alterations in the ridges of the fingerprints that can be seen in certain skin conditions like scleroderma, eczema, acanthosis nigricans. And then last is loss of pattern with ridge atrophy. So there is certain atrophy of ridge, so that the pattern of the fingerprint starts to be seen as a different kind of a fingerprint. So there is no complete loss of fingerprint, but because the ridges atrophy somewhere in between. For example, if I say that this is how somebody's fingerprint may be having an appearance, okay, and in lots of areas there is an atrophy of ridge, let's say like this. Hold on. If the fingerprint was like this, and in lots of areas there is atrophy of ridge affecting the pattern of fingerprint very differently, right? It does not look like the same fingerprint that was before the ridge atrophy. That can be seen with celiac disease. This can be seen with celiac disease, and that was one of the component of the question, that permanent damage has happened with that victim which has come to jail, and the reasons for that permanent damage could be leprosy, radiation, electrocution, right? And so when he comes to jail and his fresh fingerprints are taken, they cannot be reduced. Let's move on and let's take up our last two questions on toxicology. Correct answer has been given by TM Dihana, right? Great. So let's take up question number 1. A person is given some powder mixed with food. Okay. So there is some powder which has been given to a person mixed with food. After few hours, he complains of colicky abdominal pain. So there is colicky abdominal pain after few hours, not immediately. Also there is thirst, right? So they are very typical GI symptoms. Let's mark them. GIT, so GIT symptoms are given in the question, followed by vomiting and diarrhea, again extension of GIT symptoms itself. Diarrhea is also bloody. In hospital, his BP is found low, so hypotension is seen. He is treated well and he survives. Okay. 2 weeks later, he develops peripheral neuropathy also. What could be the responsible substance? So after the whole jigsaw puzzle, the same question has been asked, what could be the response? Now, what do we see here is involvement of GI system, then falling of BP in that acute phase when the person has come to hospital, even that is important. And 2 weeks later there is development of neuropathy. Okay. So, we also have a neuropathic component. When you dissect a question like this and when you see the options, all metallic poisons are given as option: arsenic, mercury, thallium and iron. There are two poisons which can present a picture like this. One is arsenic, one is thallium. Okay. Mercury can also present a picture like this, but then severe colicky abdominal pain with acute GI symptoms with bloody diarrhea is not a component of mercury. Now, when we talk about bloody diarrhea, it will not be present in thallium, it will be present in arsenic. When we will talk about neuropathy, it is present in arsenic as well, it is present in thallium. If we talk about colicky abdominal pain and thirst, it is largely present in arsenic. It could be a component of thallium ingestion. Can it be? No. The answer is absolute no. Why? Because there is one thing which is very important about thallium is what do we need to remember about thallium is it is very well mixed with water and is tasteless, and that makes thallium a very important homicidal poison, because you can mix it in food substances and the person will not get a taste of it, and when he does not get the taste of it, that a foreign substance has been sent into his body, there are not many predominant GI symptoms. Reading this much of question only and having no other discussion is around it, the answer pop itself. GI symptoms, bloody diarrhea, low BP, neuropathy, we are talking about arsenic, and this arsenic poisoning is seen in gastroenteric type arsenic poisoning. Now, there is fulminant arsenic poisoning when 3 to 5 grams of high dose of arsenic is taken. Everything happens so fast that nobody understands what has happened. Gastroenteric type, which is more common in an acute poisoning, is where the GI symptoms predominate. The diarrhea primarily is bloody, and then later on it converts into a rice water stool cholera like diarrhea. Okay. Neuropathy is also very important feature that may be seen in arsenic poisoning. Now, in INI-CET questions, examiner always kind of presents two metallic poisons in front of each other in such a way that certain symptoms are produced by each of them, right, and the most common competitors in this area are arsenic and thallium itself. So, let us see how should we be armed enough to be able to differentiate the features of arsenic versus thallium. Look at 4 areas. First of all, both arsenic and thallium, they tend to produce alopecia. So, alopecia is seen in both arsenic and thallium, but with thallium the alopecia is marked in lateral 1/3 of eyebrows. So, lateral 1/3 of eyebrows are commonly involved in alopecia. That's hallmark of thallium alopecia. On the other hand, arsenic, it involves body and scalp hair, right? Skin rash, both arsenic and thallium produces skin rash. In thallium, we have maculopapular rash resembling butterfly on cheeks. So, butterfly kind of a rash develops on cheek in case of thallium, whereas if you will see a case of arsenic, the rash are number 1 raindrop pigmentation, so round raindrops kind of hypo or hyper pigmented areas develop on skin, both hypo and hyper. That is why it is also called as salt and pepper kind of rash. Okay. And then we can have hyperkeratosis of palms and soles, which are again very typical of arsenic rashes or skin manifestation. Peripheral neuropathy, both have peripheral neuropathy. In both of them, sensory more than motor, both. Okay. Psychosis, now that's one differentiating feature. Thallium has, arsenic does not show any psychiatric symptoms, right? And if you see any other important finding, then arsenic show GIT symptoms, whereas thallium almost none of the GIT symptoms. Okay. So, these are typical 4-5 areas from where the examiner keeps on asking or test the knowledge of. If we can remember minimum this much regarding the difference between arsenic and thallium, should be able to answer a metallic poison correctly. The most common asked metallic poison in exam is arsenic, right? Great, let us move on. And now we are taking the last question for the evening. The question says, a 14-year-old child comes to emergency in evening with salivation, diarrhea, watery eyes. Right. So, we have a very typical building up of question here: salivation, diarrhea, watery eyes. I have read this much only, and it has already started to ring a bell in my mind that I am looking at a high cholinergic state in that child. He is not passed urine after returning home from agricultural farm of his friend's father. Oh, not passed. It should not be passed. Not passed. The question here is wrong. Should not be not passed. He has passed urine in pants, right, after returning from agricultural farm of his friends. Okay. Father since morning, what drug would be an ideal antidote for his condition? Because why I have cut the question as not passed, because it looks to be a situation of high cholinergic state in the body, and if there is high cholinergic state in the body, there would be dysuria, not anuria. Okay, there will be dysuria. A lot of urine will be passed with slightest of urinary impulses, because this happens in cases of organophosphorus poisoning. And the clincher of the question is uh, that he has returned from agricultural farm of his friend's father, where in farming organophosphorus insecticides are commonly utilized. So, whole in all, the question is pointing towards a very common kind of poisoning, which is organophosphorus poisoning, and the answer is very simple. The answer is the antidote which has to be given, which is atropine, right? The answer is very simple. Organophosphorus poisoning, which is a very important area in pharmacology, also in forensic medicine also. Forensic medicine talks about the situations of organophosphorus poisoning, pharmacology talks about the treatment of organophosphorus poisoning, and this question, although is age old, but still keeps on coming in the examination repeatedly because of it being so common condition in clinical presentations in our hospital, right? So, time and again we keep seeing questions made with different histories and different presentations. The answer remains the same: organophosphorus poisoning, right? So, there wasn't much to discuss in organophosphorus poisoning. I hope everybody understands the poisoning pretty well, because one of the most common discussed poison in pharma as well as forensic medicine, right? With that, we come to end of this session, and I wanted to leave all of you with the blast itself. And the blast is a very simple and very rhyming sentence, which says, best believe is, right? Believe in yourself, do all the preps with these two simple lines. Best of luck to all. With that, we'll end the session here, and yeah, hopefully you all had a wonderful prep coming in front of you till the time of your exam.